Welcome, physicians in training, and welcome to MedUPTICK, where we are committed to elevating your clinical mastery. Today, we're going to participate in a USMLE-Style vignette walkthrough regarding CNS neuropathology. Come on in and let's get started. Welcome back. Let's tackle this clinical vignette step by step. Pay close attention to the patient's symptoms, exam findings, and family history. These are all essential clues. Along the way, we'll discuss possible diagnoses and why certain conditions are more or less likely. Which of the following is the most likely diagnosis? A 16-year-old boy is brought to neurology clinic by his parents due to progressive difficulty walking and frequent falls over the past 2 years. He has developed slurred speech, worsening coordination, and a subtle intention tremor. The symptoms of progressive difficulty walking, frequent falls, slurred speech, and clumsiness over 2 years are suggestive of a neuromuscular or neurodegenerative disorder. The first conditions that come to mind include neuromuscular dystrophy and hereditary spastic paraplegia. He denies any history of trauma, vision problems, or headaches. The absence of trauma, vision problems, or headaches shifts the focus further towards chronic, non-inflammatory neuromuscular or hereditary conditions. This makes structural or acquired CNS causes such as brain tumor or hydrocephalus less likely and supports consideration of inherited disorders like muscular dystrophies, Friedreich's ataxia, or other spinocerebellar ataxias. His medical history includes mild scoliosis noted in childhood. There is a family history of similar problems and an uncle who started using a wheelchair by age 30. The patient takes no medications. The history of mild scoliosis, progressive symptoms, and a family history of similar issues in an uncle suggests an autosomal recessive or X-linked disorder. On physical examination, his blood pressure is 110/70, heart rate 85 beats per minute, and respiratory rate 16 breaths per minute. Neurological examination reveals absent deep tendon reflexes in the lower limbs, loss of vibration and proprioception in the feet, positive Romberg sign, mild horizontal nystagmus, intention tremor when performing finger-to-nose testing. The neurological exam findings suggest both peripheral and central nervous system involvement. The absent lower limb reflexes and sensory loss point to peripheral neuropathy, while nystagmus, intention tremor, and positive Romberg sign indicate cerebellar and proprioceptive deficits. An electrocardiogram demonstrates left ventricular hypertrophy. Genetic testing confirms an expanded GAA trinucleotide repeat on chromosome 9q13. Which of the following is the most likely diagnosis? The findings of left ventricular hypertrophy on ECG, the expanded GAA trinucleotide repeat on chromosome 9q13, and the clinical presentation highly suggest Friedreich's ataxia. However, if you didn't remember, this genetic defect association or other plausible differential diagnoses include spinocerebellar ataxia, Charcot-Marie Tooth disease, vitamin E deficiency ataxia, and mitochondrial disorders. Now let's review the answer choices. A. Wilson's disease. Although Wilson's disease is autosomal recessive and involves extrapyramidal features like rigidity, tremor, or dystonia, it is inconsistent with this vignette because Wilson's disease lacks cardiac involvement, peripheral neuropathy, and progressive ataxia. Also, Wilson's disease typically presents with liver dysfunction and psychiatric symptoms, which are not seen in this patient, so we can eliminate this answer. B. Multiple sclerosis. Multiple sclerosis tends to present between ages 20 to 40 with a relapsing remitting course rather than a steady progressive decline described in this vignette. MS typically has upper motor neuron symptoms such as hyperreflexia, spasticity, and is not hereditary. Both points contrast this vignette describing a likely autosomal recessive or X-linked inheritance pattern and peripheral neuropathy. Hence, we can eliminate multiple sclerosis. C. Spinocerebellar ataxia. Spinocerebellar ataxia, SCA patients can present with progressive ataxia with hallmark features of frequent falling, difficulty walking, and balance issues. Additionally, SCA has symptoms of cerebellar involvement, such as mild horizontal nystagmus, intention tremor, follows a hereditary pattern, and may involve peripheral neuropathy. However, it does not have cardiac involvement, often upper motor neuron manifestations, and is associated with genetic abnormalities that do not include trinucleotide repeats. So this is not the best answer to this question. D. Friedreich's ataxia. We know Friedreich's ataxia is caused by trinucleotide repeat GAA expansion of the frataxin gene. If you remember this fact, it makes the question straightforward, but other vignette clues point to Friedreich's ataxia if you are unsure about the trinucleotide repeat. The hallmark features of FA support slowly worsening ataxia. There is confirmation of CNS involvement with intention tremor, horizontal nystagmus, and cerebellar ataxia. Left ventricular hypertrophy on ECG is a classic extracerebral manifestation of FA, which often includes hypertrophic cardiomyopathy. The patient's uncle having similar progressive symptoms and wheelchair use by 30 supports a hereditary condition, and FA follows an autosomal recessive inheritance pattern. The summative analysis supports FA as the best answer, but let's discuss answer choice E for completeness. Charcot-Marie tooth disease. Charcot-Marie tooth disease can present with progressive difficulty walking due to distal muscle weakness leading to frequent falls, loss of proprioception or vibration, with absent deep tendon reflexes, particularly in the lower limbs, demonstrating peripheral neuropathy. Follows an autosomal dominant or X-linked inheritance pattern, and sometimes displays mild scoliosis. But the main differences from the vignette are MCT does not have cardiac involvement, cerebellar signs, such as nystagmus, and is associated with gene mutations like PMP22, not a trinucleotide repeat. This brings us to the end of this USMLE-Style vignette deep dive walkthrough. Hopefully you've received a refresher on multiple pathologies with various neurologic and autoimmune dysfunctions. Check out the free Friedreich's ataxia PDF summary and hit that like button if you received value from watching this video. Share your feedback in the comment section to help direct the content on this channel. As a new channel, we aim to serve your preferences best. Be sure to check out the additional high-yield content reinforcement via question reviews and other exam prep tips by subscribing to the channel and hitting that notifications bell. Future episodes will have a prize giveaway after we reach our first 500 subscribers. The winner will be selected from our subscribed member list, so don't miss out. Until next time, stay sharp and focused and continue to elevate your clinical mastery.